Monroe with the third.
Oh, yeah. One of the PP guys is moving around for the on-sales discharge. I'm as a big deal.
Driver only, sir. Okay. Driver. Good morning, everyone. The topic of today's presentation is ventricular system and normal pressure hydrocephalus. And my moderator is Dr. Shalima. First, we'll discuss the anatomy of the ventricles. The ventricles are four fluid-filled cavities located within the brain. These are the two lateral ventricles, the third ventricle and the fourth ventricle. The two lateral ventricles communicate through the interventricular foramen of Monroe with the third ventricle. The third ventricle is connected to the fourth ventricle by the narrow cerebral aqueduct of Sylvius. The fourth ventricle is continuous with the narrow central canal of the spinal cord. The central canal in the spinal cord has a small dilatation at its inferior end, referred to as the terminal ventricle. The ventricles are lined throughout the ependyma and are filled with cerebrospinal fluid. The ventricles are developmentally derived from the cavity of the neural tube. This is a diagram showing the flow of CSF. These are the two lateral ventricles, and through the foramen of Monroe, it goes to the third ventricle. From the third ventricle to the cerebral aqueduct of Sylvius to the fourth ventricle, and through the fourth ventricle there are two openings: the foramen of Luschka, from where it again goes into the brain circulation, and the foramen of Magentic, through which it enters the spinal cord and it terminates as a terminal ventricle. The lateral ventricle. These are two large lateral ventricles, and one is present in each cerebral hemisphere. The ventricles are roughly C-shaped cavity and may be divided into body, which occupies the parietal lobe, frontal horn, inferior horn, and the posterior horn. The anterior horn occupies the frontal lobe, the inferior horn occupies the temporal lobe, and the posterior horn occupies the occipital lobe. The choroid plexus of the lateral ventricle projects into the choroid plexus projects into the ventricle on its medial aspect and is a vascular fringe composed of pia mater covered with the ependymal lining of the ventricular cavity. The function of the choroid plexus is to produce cerebrospinal fluid. The third ventricle is a slit-like cleft between the two thalami. It communicates anteriorly with the lateral ventricle to the interventricular foramen of Monroe, and posteriorly with the fourth ventricle to the cerebral aqueduct of Sylvius. The choroid plexus of third ventricle, the blood supply of the tela choroidea, and therefore also the choroid plexus of the third and lateral ventricles, is derived from the choroidal branches of the internal carotid and the basilar arteries. The venous blood drains into the internal cerebral veins, which unite to form the great cerebral vein, and the great cerebral vein then joins the inferior sagittal sinus to form the straight sinus. The fourth ventricle, it is a tent-shaped cavity filled with cerebrospinal fluid. It is situated anterior to the cerebellum and posterior to the pons and the superior half of the medulla oblongata. It is lined with ependyma and is continuous above with the cerebral aqueduct of the midbrain and below with the central canal of the medulla oblongata and the spinal cord. The choroid plexus of the fourth ventricle, the blood supply to the plexus is from the posterior inferior cerebellar arteries. Now we'll discuss normal pressure hydrocephalus. Prevalence. NPH is a rare disease. One Norwegian study estimated the prevalence of NPH to be around 21.9 per 1 lakh population and the incidence to be around 5.5 per 1 lakh population. A more recent population-based study in Sweden found the prevalence of probable idiopathic NPH was 0.2% in those aged 70 to 79 years and 5.9% in those aged 80 years or older, suggesting that the disorder is more common than previously thought. NPH refers to enlarged ventricles disproportionate to the degree of cortical atrophy on neuroimaging in patients with a normal opening pressure on lumbar puncture. Idiopathic normal pressure hydrocephalus is a neurological disorder that generally presents after the sixth decade of life. It has been associated with hypertension, hypercholesterolemia, diabetes, and alcohol use, but the basis for these associations is unclear. The triad for NPHs are urinary incontinence, cognitive disability, and gait dysfunction. First, we'll discuss gait disturbances. The gait disturbance in NPH is referred to as an apraxic or magnetic gait. The typical gait is slow with a wide base and small steps and turns using multiple steps. There is no mask-like face, hand tremors, arm rigidity, or impaired fine finger movements as in typical Parkinson's disease. Postural instability and falls are common in NPH. The gait disorder is the feature most responsive to treatment. As we can see in this diagram, there is a forward-leaning stance. The gait is magnetic, bradykinetic, shuffling, and short step. There is decreased step height, decreased stride length, and decreased cadence, and impaired balance. Cognitive disorder. Stretching of the frontal white matter pathways results in a cognitive profile characterized by frontal executive dysfunction, including cognitive slowing, impaired abstract thinking, and impaired shit shifting. This is the diagnostic criteria, Japanese diagnostic criteria for idiopathic normal pressure hydrocephalus. It is divided into three categories: possible idiopathic normal pressure hydrocephalus, probable, and definite idiopathic normal pressure hydrocephalus. Genetics. Numerous reports of familial idiopathic normal pressure hydrocephalus have been published, suggesting a genetic contribution to the disorder. Several of the involved pedigrees display an autosomal dominant transmission. Specific genes associated with INPH include CFAP43, NME8, and SFMBT1. All of these encode proteins that have been implicated in the function of ciliated epithelia. Because mutation in cilia-related genes are a common cause of congenital hydrocephalus, these reports raise the possibility that defects in cilia may predispose to adult onset idiopathic normal pressure hydrocephalus as well. Neuroimaging. The hallmark neuroimaging feature is ventricular enlargement, which is out of proportion to atrophy. When atrophy is proportionate to ventricular enlargement, the term ex vacuo hydrocephalus is used. The Evans index is used to assess the ventriculomegaly. It is defined as the maximal diameter of the frontal horns to the largest width of the inner tables of the cranium, and with the ratio of more than 0.30 considered consistent ventriculomegaly. Recently, the MRI finding of disproportionately enlarged subarachnoid space hydrocephalus was reported. DESH is defined as the presence of a tight convexity in conjunction with enlarged sylvian fissure and associated hydrocephalus. And these are the neuroimaging. In this diagram, we can see the Evans index, which is from right ventricle, the distance between the right ventricle and the left lateral ventricle, and the largest interaxial distance between the cranium, and a ratio of more than 3 suggestive of hydrocephalus. And here we can see the presentation of DESH, disproportionately enlarged subarachnoid. Here there is tight convexity of the sylvian fissure with the enlargement of the ventricles. Diagnostic tests. TAP test. The most common approach is a large volume 30 to 50 ml lumbar TAP test, where gait is tested before and within 30 minutes of the TAP. Improved gait after CSF, improved gait after drainage constitutes a positive result and predicts a better response to shunting. A more invasive method is placement of a temporary catheter in the lumbar CSF space and drainage of CSF at 10 cc per hour for a period of 1 to 3 days. This is more sensitive, but it has a small risk of infection. Other tests include intracranial pressure monitoring and CSF infusion tests. Now, the approach to treatment in case of NPH. First, a patient with ventriculomegaly, gait dysfunction, incontinence, or with or without cognitive impairment is assessed. If there are any other causes of gait dysfunction, they have to be ruled out. For example, Parkinson's disease, cervical myelopathy, vitamin deficiencies, and hypothyroidism. If no, then we proceed with an MRI. If the MRI findings are typical of NPH, then we do a high volume LP or lumbar drain trial. If the opening pressure is more than 25 centimeter of water and there is increased cell count, then we investigate the causes of high intracranial pressure. If the opening pressure is less than 25, then we see that there is a clear response to the removal of CSF, then NPH is very likely and VP shunt is done. If there is no response to clinical CSF removal, and then NPH is less likely, but if still the suspicion is high, we may consider a VP shunt. And then if there is if MRI findings suggest typical NPH, then if yes, then we'll follow the same procedure. If no, then we can rule out X-ray hydrocephalus. We can consider neuropsychological testing for neurodegenerative changes. And if the clinical suspicion is still high, then we follow the same procedure. We do an LP, high volume LP drain, and we see if there is response to CSF removal, then we do VP shunt. And if no, then we, if the suspicion is high, then we can proceed with the VP shunt. Now the complications of shunt placement. Here, this is the VP wall, which regulates the amount of CSF which has to be drained. In this image, we can see that uh, the blue arrow shows that the ventricles have completely collapsed, which indicates that the wall was not correctly placed, or the magnetic wall was not correctly placed, and CSF, large amount of CSF was drained. And in this, the second diagram, the green arrows show, these also show over drainage of the system. These are my references.
The role of CSF flow.
Yes, sir. So it has a significant role in this. The transepidemic flow studies and CSF flowmetry.
But these angles involved,
Yes, sir.
these are very, very important.
So this is the callosal angle.
Callosal angle, corpus callosum. But where, at what section it is measured? Because corpus callosum will be there through a very the longitudinally कहाँ पर assess करेंगे?
So perpendicular to the anterior posterior commissure plane.
Yes, very good. So at posterior commissure level, trajectory plane जाएगा, वहाँ पे you will assess the angle. So line which will coincide with that anterior commissure and posterior commissure, which will join it. This is important. I think this radiologist will do for you. And then this Evans index is important. Now, what is this dash? Dash is very important because dash will help us in actually diagnosing it. We need not depend upon just also. We can also see dash. Am I right?
So
this one.
Now there is tight
there are three sections. So the first section, you can see this is a coronal section, and you can see Selvin fissure is very prominent. It's a Selvin fissure, which are very, very prominent. So Selvin fissures are more prominent, and when you go to the vertex, yes, vertex. You can see that there is a cluttering of various sulfide at vertex. So this is what they call as a disproportionate subarachnoid spaces. Similarly, second window, here you can see very Selvin atrophy, almost. But when you go to the anterior table, there is a rush of various sulcides and ladders. They evade with each other. So this is what this dash. So dash, the help of dash, we can calculate. Whether we can assume that patient is NPH. But all these angles which are given below, these can be done with the help of CT imaging. But dash, very clearly we can see with MRI. Obviously, clinical suspicion is how much drainage they do.
So 30 to 50, which is the diagnostic test, CC, I believe so.
And go to the last slide. This is what actually I had forwarded. So this is the shunt which they have placed. First window to drain CSF. What happens because there is no cortical atrophy or very mild cortical atrophy, there is pressure on our cortices. So जैसे ही वो pressure कम हुआ, because of over drainage, the ventricles collapsed, and that is why you can't see any ventricle because of over drainage. Then they corrected it in the second. But during correction, you can see subarachnoid space. There are some densities, green arrows between the sulci gyri and the table. So those are subdural hemorrhages, which are very mild, which are part of this process. Third figure we didn't share because that was a rare complication. This is what I want to say, that and this white thing is this is the shunt.
theoretical pathophysiology says that since the age of onset is a little late, so late in life, this may occur to loss of a certain blood vessel in the elastic arteries, as a which may occur due to atherosclerosis. As a result, this hypoperfusion, which may in turn lead to increased brain pulsation. As a result, there is increased tearing as well as compressive forces. So there is cerebral autocompression, which mainly manifests as ventricular edema.
If you go to the other pictures, I think I agree with Dr. Shiva. Ishani has other MRIs. So you can see the second row. Now the periventricular hyperintensities are set. So because of this theory, which now she's saying that because of the age, these hyperintensities, the ventricle walls become more tensed. So it's a kind of an obstructive hyperventilus where the absorption doesn't happen. So absorption doesn't happen. The CSF. Now in that process, there is a shearing forces in your long tracts. So medially are your tracts which go to your legs. So that is why they are more affected. So gait becomes magnetic. And as Dr. Anushka said, that there are other shearing forces on those callosal pathways, on those communication pathways. That is why these executive deficits come. It is not an enigmatic issue. It's mainly explained by the physics. Just going on.
Sure.
Yes, it is. Remaining complex. So, which area of the brain is responsible for the bowel and bladder control? इसी से पता चल जाएगा कि क्योंकि कैलोसम इन्वॉल्व है कैलोसल एंगल भी है कैलोसम एंगल शुड नॉट बी मोर देन 90 should be less than 90 so pericallosal cortex is responsible paracentral lobule
Who is walking with one thing? He is walking with 2 kilos below the water. Who is walking with not possible? In dementia, also there are 2 traits that we go after. One is parent dementia with adult, who is socially dependent, but independent at home. He is not even dependent at home as well. Who is totally dependent. And then the one thing is instinctive unity and confidence. That's also a slow breed. One is given this person. We sometimes at night for people.
I want to discuss patient hira patient hira में NPH सस्पेक्ट कर रहे थे अल्कोहल विड्रॉल के जो सिर्फ 1.9 पे थे
So better is कि ना उनके neuroimaging से can be many patients will get this tried ocular decline, we get incontinence, we get gait apraxia. What we lack is matching the clinical findings with the neuroimaging data. So depend blindly upon the radiology colleagues. That is what we can improve is we can match them with the radiology data with the films and assess it by us. And then go for CSF flow studies. If we find something, then we can refer them to neurosurgery. Because that is what we can do at our level. Intervention we can't do, but at least this amount of assimilation we can. So we need not refer blindly. They'll write a CSF flow study. Why not? We can diagnose or have a clinical suspicion, do a flow study, and then refer. prognosis. So what happens if they are conscious and
Bad prognosis.
long term, slowly they'll degenerate?
Conscious.
Japanese criteria, can you read that criteria?
First, there is possible idiopathic non-patient hydrocephalus, which has to meet all the five of the following. Number one, individuals who develop symptoms in their 60s or older. Second, more than one of the clinical triad, cognitive impairment, urinary incontinence, and gait disturbances. Ventricular dilatation, that means Ivan index more than 0.3. Number four, above mentioned symptoms cannot be explained by any other neurological or neurological disease. And number five, preceding diseases possibly causing ventricular dilatation are not obvious, including subarachnoid hemorrhage, meningitis, head injury, congenital hydrocephalus, and epileptic stenosis. Then possible NPH supportive features it can be small stride, shuffle, instability during walking, increased instability and turning. And symptoms which progress slowly, however, sometimes the undulating course, including temporal discontinuation of development and exacerbation, is observed. Gait disorder is the most prevalent feature, followed by cognitive impairment and urinary incontinence. Cognitive impairment is detected on cognitive tests. We can do an MMSE of the patient. Other neurological diseases such as Parkinson's disease, Alzheimer's disease, cerebral vascular diseases may coexist. However, all the diseases should be mild. Then periventricular changes are not essential, and measurement of CSF is useful for differentiation from other dementias. Then second is probable NPH, which meets all of the following three features. Number one, which meets the criteria for possible NPH. Second, CSF pressure should be less than 200 mm of water, and normal CSF content should be present. And number three, one of the following three investigational features should be present. Number one, neuroimaging of narrowing of the sulci and subarachnoid spaces over the high convexity midline surface dish, which we saw again in the neuroimaging. Second, improvement of symptoms after CSF tap test and CSF drainage test. Then third is definite idiopathic non-patient hydrocephalus. There's improvement of symptoms after the shunt procedure.
But the pressure, which is pressure on opening, there it was quoted as 45, here it is 20.
So वो units है वो centimeter में से
आप देखिए, so but whether it is 25, 20 in millimeter Hg, what is the pressure?
So 10 to 15.
I don't check correctly.
So this is from Bradley's neurology. Answer the reference others of neurological surgery. Yes, sir.
So we keep changing.
Yes.
What is a, it must be a one standard. We currently in terms of the library, I think it's an MCQ. Any Ankita? I think with history wala themes and patterns was actually bad. We can always start with some slides of history, then come into the topic per se, then ending it with future recommendations. Otherwise, you're busy. Your comments? Basically, the point is this topic is important for patient athlete. Decline, continence. We should know we should know suspicion कब रखते हैं. We can't depend upon radiology. That will kill a lot of time. Busy OPD में तब time नहीं देता. And then we should know कि CSF लोग and then quickly doing it so that we take patient to some logical end and then subsequently referring. That will actually bring more clarity to us, to the patient, and save time. And neurosurgery colleagues will be very happy that we have done all the things and then subsequently sending it to